We are live.
Yeah, namaste, hello, good morning to Dr. Bram and all the viewers in the Canada, and good evening to all the viewers in India. So I am Dr. Archana Kumari, Chairperson of Quiz Committee of FOGSI, and your host for today's podcast series, episode 143. So today I'm very honored to have a very eminent guest faculty of international fame, Dr. Bram Rashwark, who is a clinician and phenomenal researcher with H-index of 82. So welcome, Dr. Bram. And let me tell you that this podcast series is actually a brainchild of our President FOGSI, Dr. Sunita Tandulwadkar, Madam. She had joined for a moment, but now she is unable because of the network issues. So on her behalf, Dr. Ashwini Kale, who is the Joint Secretary of FOGSI, is here to welcome you. So let me just for information tell you that this podcast series, we are 30 committee chairpersons of FOGSI, and on each committed day to one chairperson, at every day at 8 p.m. we have a creative dialogue with somebody either from medicine or maybe sports or maybe politics or maybe bureaucrats or maybe spiritual field. So where we have a very creative dialogue and lots of learning. So today also we are going to have a very engaging discussion on evidence-based medicine, especially in relation to the critical care. But before that, I would like to welcome Dr. Ashwini Kale. She is a renowned gynecologist, fertility specialist from Pune, and she is the force behind all the projects of President of FOGSI. She is working very hard for all the presidential projects and for all the commitments of FOGSI. So welcome, Ashwini, and may I invite you for the welcome address.
Yeah, thank you so much, Archana Madam. A very warm welcome to Dr. Brand from Canada. It's really so good to see you early in the morning joining from Canada. So all our viewers are very lucky to have you here. To tell you that FOGSI is an organization of 46,000 gynecologists, one of the very largest organizations of super specialists, which is spread across India. And we have multiple projects going on under the leadership of Dr. Sunita Tandulwadkar, who's our president currently. So one of the major projects is Sampurna, which is on preconception care. So just on 18th, we launched this project with SIF Foundation, where we are going to optimize all the parameters for the preconception care, look after her nutrition, and also the other parameters like blood sugars and hypertension, and actually make it a very holistic care for the women before she actually becomes pregnant and delivers, so that automatically a maternal mortality and morbidity reduces to even less than 80 now. So that is what we are looking at. As a part of FOGSI, this year we have undertaken 7 studies across India, which are based on anemia. One is postmenopausal bleeding. One is the usage of contraception across the country. And we are planning to publish these publications in our national journal, which is the Jogi. So these are the various projects. And another project is against cervical cancer awareness, which is called as the Nirmal Banaras Abhiyan. You may have heard of the city of Varanasi, which we have undertaken. And in that small city, we are seeing to it that each and every woman is at least screened for cancer cervix. She's made aware of this vaccine, and at least we try and vaccinate 70%, which is the target. So these are all the projects that we are running under FOGSI. Another is this podcast, where every day one of the committee chairpersons interviews a person who is a professional and an accomplished achiever in their own field. It could be a politician, academician, a researcher. So this is how every day there's a 45 to 50-minute crisp dialogue. And we're very fortunate to have you today. So I think I'll join in from the viewers link and enjoy this podcast. And Dr. Bram, you're more than welcome for all our conferences as well till January. Let us know your schedule anytime, and probably Archana Madam will coordinate with you for that. Thank you so much. Thank you, Archana Madam. I'll join in from the viewers list.
Yeah, thank you, Ashwini. Thank you. Bye. So it's now time to introduce our guest speaker, Dr. Bram Rashwark. He's an accomplished clinician and researcher, currently serving as Associate Professor in the Department of Medicine critical care medicine at McMaster University with a joint appointment in the Department of Health Research Methods, Evidence and Impact. He holds an MSc in Health Research Methodology from McMaster University, an MD from University of Ottawa, where he was a class valedictorian, and BSc in Genetics from University of Western Ontario. In his clinical and academic role, Dr. Rashwark serves as the MD site lead and research lead for the Zuravinsky Hospital ICU. He's the chair-elect for the Canadian Critical Care Trial Group and plays leading roles in several guideline initiatives, including the chair of SCCM guidelines on critical illness in older adults and also the vice co-chair of surviving sepsis guidelines. He also serves as an associate editor of major journals such as Critical Care Medicine, Chest, and ACP Journal Club. Dr. Rashwark has made a significant contribution to research with over 458 peer-reviewed publications, H-index of 82, and more than 43,000 publications till June 2025. That is an amazing achievement, Dr. Bram. I must congratulate you for that. He has secured so many $1 million for as a research fund, either as PI or co-PI. He's a very passionate educator and mentor. He coordinates and teaches courses in health research methodology and has supervised numerous master's and PhD students. His work has been recognized through several honors, including FCCM designation in 2021, the Hamilton Health Sciences Early Career Award in 2019, and ICU Fellow of the Year Award at McMaster. And I've also had the opportunity to meet him during one of his great workshop at RIMS Ranchi, and I know how wonderful teacher and mentor he is. So welcome, Dr. Bram. Today we'll be having a very engaging discussion on the evidence-based medicine, especially how to bridge the gap between evidence and practice in medicine. So
thank you, Archana, for the incredibly kind introduction. Hello to all. It's absolutely my pleasure to be here and speaking with you today. It seems like fantastic work that your organization has been doing over the years. I actually just spoke with our SOGC around guidelines and grade, our Society of Obstetricians and Gynecologists in Canada, and so also have strong connections with organizations such as yours. But I really appreciate the invitation and can't wait to be chatting today.
So let us start our conversation. So Dr. Bram, your work sits at the intersection of clinical care and academic research. So how have you balanced the demands of ICU with your role as a guideline developer and researcher?
I think this is a struggle that we all face, Archana, right? Is that, those that do clinical work, no matter what our outside challenges are, we all have those outside, things that we have to deal with, whether it be family, whether it be teaching, administration, research. And it is challenging. I think you mentioned I work as an ICU doctor in Canada, and we do weeks on service in the ICU. I just came off of a very busy week in the last week, and trying to balance that with research and guideline efforts and guideline panels where the work doesn't stop, and you're having to find different hours of the day, night, waking up early in the morning, working late into the evening outside of clinical care responsibilities to be able to work on this. But that's not a unique story. I know we all face those challenges in all parts of our lives as clinicians and researchers. I think that there's, in fact, actually a huge benefit to being able to sit at that overlap between clinical medicine and research. And you're able to understand what the most pressing issues, I think the best researchers, the best guideline methodologists are those that are also clinicians. And, I interact with many that aren't, and you lose that element of what's important to patients and what's important to clinicians. And I think it gives us a unique perspective on things to be able to sort of have one foot in both doors and to be able to focus in on what's crucial.
Yeah, of course. Clinician can better understand what is actually there in practice. So they ought to be a good researcher, I can understand. But what actually inspired you to move beyond bedside care and contribute to actually development of evidence-based guidelines?
I think Archen, I was fortunate being at McMaster University. We're the home of evidence-based medicine. For those that didn't know, that term evidence-based medicine was invented at McMaster, and even guidelines in grade. We have some of the ancestors of guideline development in Gordon Guyatt, who you met when he was in Ranchi
Yeah,
with
of
me, and
course.
Holger Schunemann is another individual. These were the folks that created grade. And so I think early in my training, I had the opportunity for great mentors when it came to guideline development. And as an early career researcher, I can't understate the role that this played in guiding my future and my academic career. Being able to sit on guideline panels at the European Society of Intensive Care Medicine or the Society of Critical Care Medicine as a junior methodologist, learning the ranks, getting to interact with these fathers and mothers of critical care research that have shaped the way that we do medicine, provided such a unique opportunity for me. I think it was super beneficial for me as an early career researcher, but it was also very inspiring to see how our impact could change critical care worldwide. You can do research all you want, you can practice in your local center, but here was an opportunity to influence clinical practice guidelines, which literally dictates care in hundreds and thousands of centers, and to be able to best encapsulate the research that was done and to inform best practices was such a unique opportunity. And I think I've been able to now, over the years, given those early experiences, move forward in mentoring the next generation of guideline methodologists and researchers, and trying to show them that same opportunity, which is, I think, humbled to be able to play this role in clinical medicine.
Yeah, that is so inspiring also, getting mentors, and now you are mentoring your juniors. So that continuity has to be there. But would you like to describe how your affiliation with Cochrane Canada and McMaster shape your work?
Absolutely. Like I say, I think I'm super fortunate to be able to practice in a place like McMaster and have the
Yeah.
guidance and mentorship and support that I have had. I can't understate the importance of those. And, many people that I've interacted with, especially juniors, have said, oh, research isn't for me, or clinical practice, like guideline methodology, not for me. And I can understand how folks that have had a poor mentorship experience or a poor early experience with research might feel that way. Whereas, those early experiences so crucial. And if you have a positive interaction, somebody that tries to support you and promote you, and I've had opportunities where some of my mentors early on have said, no, Bram, you be first author here. Like, this needs to be your project. Let me support you in taking the recognition, taking the podium for presentation at meetings. And so, I think that culture of support and mentorship at McMaster and within our research group has been absolutely so important in shaping the work that I've done, and still having folks like I was mentioning to you, Archana, that folks like Gordon Guyatt, even though he's more senior in his career, and I can still call on him anytime, pick up the phone and reach out and say, I'm having this issue with this guideline I'm working on, or I've run into this barrier with this randomized control trial, and giving his input or support. So I think it has been really, really important. I think we have a great culture of collaboration. My experiences of coming to India, I was mentioning to you, I've been fortunate since my visit to Ranchi to come a few times since with the Indian Society of Critical Care Medicine meetings. And my sense is that the community and the culture in India is similar around collaboration and shared support and
Yeah.
interest. Maybe, not developed to the same point that McMaster and the methodology support is, but the culture is very similar and one of support.
Yeah, that goes in parallel with the saying that a good leader produces a good leader. He does not produce followers. So similarly, a good mentor definitely works hard to create another level of mentor. So that's very well said. So, evidence-based medicine is the gold standard. Yet, we often struggle with the real-world application, actually. So, what are the main barriers you see in implementing evidence-based medicine in ICUs?
Yeah, it's a great question, and it can be frustrating. You see big randomized control trials published in the New England Journal and JAMA that should impact care, but it doesn't. And you're years later. Deborah Cook, a mentor of mine, did a big randomized controlled trial showing that we don't need to target tight glucose control in critically ill patients. Maybe more like 4 to 10 is okay. We don't need to use as many insulin infusions. But like translating that into practice took lots of time, and I can imagine that's frustrating for researchers to see the gap between evidence-based medicine and what actually happens at the bedside. And I'm sure it's the same in the world of obstetrics and gynecology as well.
Right. It's true.
And yeah, and so I think every situation is so unique in terms of exploring barriers. I think that, clinical practice guidelines go a long way. And I think that, there's some that are linked to academia that are constantly aware of the newest data and what's out there, aware of the most up-to-date systematic reviews and meta-analyses. But many are, especially in community or smaller centers, so busy with patient care that it's very challenging to keep up with the latest literature, very challenging. And so this is where I see the role of things like clinical practice guidelines in getting a group of experts together to synthesize the best evidence and come up with recommendations so that, practitioners that don't have time to carefully review the evidence base can fall back on these guidelines in terms of knowing what's best care in an easily digestible format. The big concern always had been is that if you go back 20 years, Archana, guidelines were just expert driven. And I think that it's been a nice transition in the last 20 years to moving towards a combination of expert and evidence and a systematic way of incorporating evidence and other factors using a methodology like GRADE has been really important. But there remain barriers, and we still see the barriers in terms of rollouts. And, I think that some of there's challenges with application of guidelines into the local jurisdiction. You see that all the time when you look at global South versus global North, and trying to roll out evidence that was maybe done in Canada or the United States, and then trying to apply it in low middle income countries. I can imagine that there's challenges with feasibility and acceptability for patients and caregivers. These are things that we need to continue to look at how we can best address.
Of course, there are challenges also as you said, between the high resource and low resource settings also in implementing all the guidelines and all the evidences. So sometimes it is actually good to have good clinical practice guidelines. So we do abide by them sometimes because evidence does not always come into practice. But of course, this is an era of evidence-based medicine. So you have worked on several international clinical practice guidelines, but just can you walk us through what it actually takes to develop these guidelines? It's not so easy. It's an exhaustive process. That is what I learned through GRADE workshop, actually.
Yeah, no, I sure can. Listen, if Archana, you gave me 2 minutes, I can tell you how to make a guideline. If you gave me 3 days, I could tell you how to make a guideline. It's just a different amount of depth. But
so you might be having only 2 minutes.
Yeah, no problem. I'll give the 2-minute version. It is more complex and challenging than folks think. And we have done a lot of work in process around guideline development in the last few years. I'd say some of the crucial steps, maybe just to walk through, and it starts with, setting your guideline panel. And in the past, again, it used to be, at least in Canada, a lot of white-haired old men that had practiced in the field for a long period of time. And I think that we've moved towards, diversity in guideline panels, including older career folks, but also early career folks for different perspectives, including a range of diversity across gender and sex, a range in diversity across disciplines. For us, that looks like including nurses and respiratory therapists, and maybe even patient perspectives on guideline panels.
Perspective is important,
which is really important. And then, assessing conflict of interest for your guideline panel, because maybe a company is sponsoring one of the panel members that has biased perspective. And so, doing a careful job at that. Setting the questions that you're going to assess. We use the PICO structure, patient's intervention comparator outcome, to set our PICO questions. And once our PICO questions are set, probably the most onerous step is we do systematic reviews for each of the questions of interest. And so we've moved in the last little while away from guidelines that address 50, 60 questions because of the workload that's involved, and tried to put together, more compact guidelines, 5, 6 questions, get it done, address these questions, move on to the next, get it published, move on to the next guideline so we can provide timely input. Once done the systematic review, we assess certainty of evidence using grade. And then, the other crucial aspect, and perhaps the last one, Archana, is to walk through the evidence to decision framework. And what that does is that you come up with recommendations which incorporate the evidence, but also incorporate the expert input from the panel, also incorporate things like costs and resources, patients' values and
Patient
preferences,
values, yeah.
acceptability, feasibility. There's a lot of factors that go into framing recommendations, which then get published in a transparent report. So it is a multi-step process. As I say, I can give a 2-minute version. Maybe that was the 3-minute version. I can give a 1-hour version. I can give a 4-hour version.
I
The
can know,
guideline methodology is complicated.
how much time normally you take to develop a guideline? It would be around a few months.
It's so different depending on the resources, depending on the time. During COVID, I think we're going to talk about it in a bit. During COVID, we did the WHO COVID guidelines that I acted as methodology chair for. And those ones, we were so much pressure and so much resources, we were turning them around in, a few weeks. We would just do one question at a time. Should we give steroids to patients with COVID? And we turned around quite quick. And then you contrast that with something like surviving sepsis, for which I'm vice chair. And there, we're doing 80 questions, 85 questions, and it takes like 2 years to work through it. So it's so variable.
So actually, during COVID times, the things were different. You have to act fast to develop always something new guideline, new evidences were coming. So the things depends on the situation also, how much time you need to develop a guideline. But you have been involved, as you said now, you have been involved in initiative during COVID-19 pandemic. So how do you think that the guidelines remain agile and adaptable, especially during the fast evolving scenarios like pandemics?
Yeah, it's a great question. And this is always the criticism of guidelines, right? Is that especially those bigger, longer efforts, Archana, is that, by the time the recommendations come out, practice has already changed, or folks already know about it. And this isn't new information because guidelines take time to do. And so, I already alluded to it a little bit. I think that one of the best ways to overcome this is the idea of, rapid single question, 2-question guidelines that, what is the most pressing issue facing obstetricians in India right now? Let's deal with that question. Let's publish it. Let's move on to the next question. Let's publish that, move on to the next question. That way, you can get evidence out there and recommendations out there quickly. Colleagues of mine started the BMJ rapid recommendation process, and that's actually evolved into the WHO COVID guidelines in that they review the literature, and as soon as they find a potentially practice-changing randomized control trial, they try and come out with the recommendation within 90 days. So, they see New England Journal, here's a new trial that impacts the care of pregnant women. Let's get a guideline panel put together quickly. Let's throw a lot of resources at getting a systematic review done quickly. They had an arrangement with BMJ where they published the guideline very rapidly with peer review. And it sort of, tried to address this idea that guidelines take too long to come out. And they were quite successful with it and applied some of those lessons with WHO. But I think this is the future, is using technology to move towards more like a living guideline structure. But it's harder than it sounds.
Yeah, I can understand. So actually, you have to prioritize the things where you have to act faster, and which is, as you told, which is the pressing issues. You have to take that question first, and then move on like that. So you already explained a little bit about the barriers you encountered in getting the clinician and institution to adopt the evidence-based guidelines. Like you develop guideline, but are all the institutions are really ready to take those guidelines? What do you think?
They're not. They're not. And I guess some tricks that we've learned maybe around adoption, we've worked really, consider guidelines knowledge translation in themselves, but there's a whole other science around knowledge translation of guidelines themselves. And, at Society of Critical Care Medicine, for example, we've brought on an implementation scientist to help with guideline dissemination and uptake. And a lot of the work he's been doing is looking at producing tools, visual aids, infographics to help with practitioners using and applying guidelines at the bedside. And so there's been some really novel and really unique aspects that's helped with. I think one of the other really helpful tools is the patient engagement piece around dissemination, because hospitals and health systems might have easy time saying to clinicians, we don't think we should adopt these guidelines, it's not a good idea, we don't have the money or the resources, but it's harder to say no to patients. And so when you have patients that are advocating for best treatments and best recommendations, it's much easier to enact change, I find.
Yes, true. So, can you describe your most challenging or impactful experience working on Cochrane review, which is, of course, thought to be a highest level of review, the best one? So, could you share a little bit about the Cochrane review?
Yeah, I'll be honest with you, Archana. Like, we have a Cochrane Center that's based at McMaster, the Canada Cochrane Center, and they are great avenues for doing systematic reviews. I have not done a ton of Cochrane reviews, and the reason why I have not done is because there's a lot of onerous requirements that sometimes I find onerous, overly onerous in doing Cochrane. So I have published probably over 100 systematic reviews in the last 10 years. Only a handful of those have been Cochrane reviews, but still in high impact journals and high impact publications. That being said, I think that there's always challenges with doing reviews or guidelines. And maybe you're not surprised, maybe you are surprised to hear that especially guidelines, always comes down to interpersonal conflict. I find so much of being a guideline methodologist, sure, doing the systematic review and summarizing the evidence, applying grade, but managing disagreements between panel members I still find the biggest challenge, requiring behind the scenes negotiation tactics and hurting people so much, right? Clinical work's the same thing. How much of clinical work is managing disagreements between learners and nurses and patients? Interpersonal stuff becomes such a big issue. But, I've come to, especially around guidelines, I've come to acknowledge you can never do a guideline without having some barrier of somebody that's threatening
some challenges, some conflicts. Yeah, it has to be there.
Some conflict, exactly.
So every expert, they will have their own way of thinking, and so interpersonal conflict do come in way of developing guidelines.
And I think being a guideline developer and being a successful guideline methodologist, you have to learn those tricks on how to avoid some of the conflicts between experts and how to resolve them.
So you must have had enough experience now of developing guidelines and methodologies. But what role do you see AI and digital tools playing in evidence synthesis and delivery in near future? Because nowadays I also see my postgraduates taking everything from ChatGPT, using AI tool for writing thesis. So what is your comment on that? What is your take on that?
I think we'd be silly to think that there's not a role for AI in the evidence synthesis process moving forward. And we've already seen lots of application, especially in things like screening as part of a systematic review and data abstraction, steps that used to be incredibly onerous, and good data to start to suggest that these AI tools with supervision can accomplish a lot of the goals in a faster time frame, might help facilitate that idea of living guidelines. I start to get nervous about, replacing expert opinion and evidence to decision when you're incorporating the different factors and patients' values and preferences and balance of benefits and harms. I think that here we still need clinician input, patient input in terms of formulating best recommendations. But I do think that there's a huge role around evidence synthesis. AI is becoming such a big part of what we do. We talk about this a lot at the journals that I work at, is that, what are we willing to tolerate in terms of AI input on research reports? What are we not willing to tolerate? How transparent do authors have to be? I think it's going to get harder and harder over the coming years as these large language learning models start to become smarter and smarter. So it's going to be, the most pressing issue in medical science, but beyond that, probably that we face as a society, as a world, is as AI becomes more present in all aspects of how we do things. But I think that for now, there are huge potential benefits, especially around evidence synthesis, and I think we need to continue to look to see how we can incorporate
initial screening and synthesis. But of course, I don't think AI is going to replace human brain, as you also told. The clinical experts, the human brain, AI, human brain is much better than AI. But of course, we can use AI as our assistant, as an additional tool, as you rightly said. Uh, how can young doctors, especially in training, be better prepared for critically evaluate and apply research in practice? And how can senior clinician can actually mentor young doctors about it? You actually already told a little bit about it in the beginning of our
Yeah,
dialogue.
I think everybody should take a grade course or evidence synthesis workshop or this sort of stuff. Even if you don't plan to be involved in guideline development or do your own meta-analyses or run your own randomized control trial, I think all clinicians, as part of our job as clinicians, need to understand how research is done and how to interpret research. And so I strongly encourage all of my trainees to pursue some sort of formal training, whether that means a master's degree or whether that means a weekend evidence synthesis workshop that's put on like the grade one that we did in Ranchi. I think it's a good idea to be able to appreciate at least what goes into these things because we all have to have an understanding of the evidence to apply it at the bedside.
Yeah, so you talked about Ranchi. So my next question is also related to that. We had a remarkable grade workshop with the help of our director, Dr. Kameshwar Prasad sir, and Dr. Gordon Gayat. So what do you recall about that workshop experience in Ranchi? How did it really feel to engage the Indian clinicians and researchers? And you also came to Kochi recently. So your take on Indian clinician and the evidence-based medicine in India.
This was my first trip to India. I think it was December of 2023
Yeah,
when we were
December
in Ranchi.
2022. Very rightly
And
remember.
it was my first time interacting with Indian doctors and although not my first time teaching grade, and I had an unbelievable experience. And I found the Indian doctors so passionate, interested, engaged, wanting to learn, smart, and from that experience, I feel like I developed connections with Indian colleagues, and including Dr. Pradeep, if you remember, intensivist that
Yeah.
has now facilitated, and Jay Prakash facilitated opportunities.
Dr. Pradeep Bhattacharya and Dr. Jayaprakash. Yeah,
Yes,
critical
exactly.
care.
Been back to
Yeah.
Kochi and I was in Calcutta 2 years ago and coming back to Chennai later this year. And I value my connection with my Indian colleagues, at least in ICU world, so much. And look forward to each time I get to return. And we've done subsequent grade workshops, and it's been great to see similar faces of folks that I had met previously. And I'll tell you, Archana, even more so. I've now mentored a few Indian colleagues within critical care to publish systematic reviews and meta-analysis using grade that we made those connections at Ranchi or at subsequent grade meetings that led from that. And now we've been able to co-publish together in large ICU journals, international ICU journals. So it's been truly a fantastic partnership.
And we are also very honored to have you and learn from you and keep on collaborating with you. We look forward to be in great connection to you. So I think I will come towards the end of our podcast, and being a quiz committee chairperson, I have a rapid fire round for you where you have to answer in one line, two line, whatever you feel like. So just say whatever comes to your mind. One medical myth you would like to see disappear.
The doctors always have the right answer. And I don't think we do always know 100% what the right answer is. And sometimes we use our best clinical judgment. But I think patients and families think that there's always one right answer to doing things.
Yeah, that's very true. The patient always think 2 + 2 is 4, but it can be 5, it can be 3 in clinical medicine. So that is something very tricky. And we have to explain patient about this fact. One book or paper that changed your perspective.
That's a tough one. There's Why Patients Revolt, and I can't remember the gentleman. He trained here in Canada. I can't remember, his name is escaping me right now, but really talking about how the patient revolution in medicine is the way to go, and patient-centered care, moving away from physician-centered care to more focusing on delivering what patients want.
Yeah, patient centered care and shared decision making is also like in obstetrics also we are now relying more on shared decision making. A medical mentor or role model you admire.
Yeah, I would pick Dr. Gordon Guyot as a
Yeah,
mentor.
I
You
was
know, the
expecting
opportunity
that
to travel
answer.
with him to India. He cares so much about his students and always available.
Yeah, that's true. Even I ditto your opinion about him. If not medicine, what alternate career might you have been taken or
I'm a big sports fan up in Canada, especially American football, baseball. I don't think I was ever good enough to play, but maybe a commentator on TV or something like this.
TV commented? That is so wonderful. Sounds nice. The most underrated clinical skill, especially in ICU or
Yeah,
in.
I mean, it's communication 100%. I feel like my clinical skills and I think I know how to resuscitate patients. I don't use that near as much as I use, my empathetic care and clear communication with families.
A country would love to visit for a medical conference.
Oh man, there's so many. India is top of the list, but I come often. Maybe Brazil. I've never been to Brazil. I'd love to go to Brazil.
Oh, I had been to Rio once for International Conference of Obstetrics and Gynecology. That's a very nice place. One innovation you wish existed in intensive care.
Maybe a better point of care testing. The big push in the last little while has been, I don't know if the same in obstetrics and gynecology, subphenotyping patients. We have such these syndromes like ARDS, sepsis, this sort of stuff, but they're not big syndromes. There's individual subpopulations, and if we could identify those subpopulations, at least from a research perspective, and start trying to treat them differently, so maybe better point of care testing to be able to identify subphenotypes.
Your favorite way to de-stress yourself after tough ICU shift, as you were telling last week, was very exhausting.
I have Archana 4 boys. They're 13, 11, 9, and 9. So I'd say just coming home and hanging out with the boys.
Yeah, I actually saw in your DP in WhatsApp 4 kids, but I didn't know all of them were boys. So that is the best way of de-stressing yourself when you enjoy with your children.
It's stressful still, but stressful for different reasons, maybe.
Yeah. Most memorable patient interaction you ever had? Just one word to describe it.
Yeah, I had a young guy that ended up with biliary atresia, ended up having a liver transplant and died post-liver transplant. But he was 23 and he was a big sports fan like me, and he gave me a jacket for my favorite sports team, and I always think so fondly of him.
Yeah, at times many of your patients touch your heart. That's true. One piece of advice you would like to give your younger self.
Hmm. Maybe don't sweat the small stuff. I think we always get so focused on the little things, but I'm a true believer that things work out in the long run as long as you do your best and try your hardest. So maybe don't worry about those little things as much.
Okay. So thank you so much, Dr. Bram. I think we have finished in time. You have another meeting to attend. So thank you so much for sharing your insights, your journey. Your work continues to inspire all the clinician and all, especially the ICU intensivist and those who actually believe in evidence-based medicine, the systematic reviews, meta-analysis. So thank you so much for joining, and hope to see you soon in India again.
That sounds great. Thank you again for the invitation. All the best. Have a great weekend.
Yeah, thank you so much. And to the viewers, thank you so much. Until our next podcast, stay tuned, stay curious, and keep on learning. And thank you, support team, for having a flawless support and flawless conduct of the podcast. So it's time to say goodbye. Maybe when I come to Canada, I will try to meet you next. Thank you. Bye.